folks than we do actually at skin color or circummoral for them. Level of consciousness. Remember that our patient that is hypercapnic can be very somnolent. They can be very sleepy, hard to arouse, hard to keep awake. They could be restless. Your patient may complain of having a headache. They may have an increased blood pressure. There may be irritability with them. There might be slurred speech. And remember, all of those things can lead to coma for the patient. So initially, they might start out restless, anxious, but if the CO2 level is increasing and we can't decrease it, they actually can become very hard to arouse and actually go into a comatose type state. So sometimes family members, if a patient does have COPD or something like that, and the CO2 level is increased beyond their normal level, will actually call the squad because they can't get the family member aroused or they can't keep them awake. And when we bring them in, we find that their CO2 level is pretty high for them, or somebody that's developing respiratory failure for other reasons. And then our last one in this section is monitoring blood gases. So I have the normal blood gas parameters for you here. Remember, your SaO2 is your pulse oximetry. So it's doing a venous sample. Your other three or your other four levels would be an arterial draw. So when we go to the hospital at UH, we were fit tested, at least 8 of my students were, and they're going to be able to care for COVID patients. There's going to be some protocols for our COVID patients because we're not going to see SaO2s in that 95%. So their protocols are going to change. They're going to be in the 80s, and if they drop into the 70s, they have to go to the unit, and there's different standards for different respiratory disease processes. And same thing with our COPD patients. We know that probably a CO2 in a 35 to 45 range is not normal for them, nor will they probably ever be normal. So you have to adapt some of these levels based on your disease process. So just keep those in mind as you're working with your patients and what's going on with them.
Are you wanting us to see another screen? I can only see you right now.
Is that all that's showing for everybody?
Yes, that's all that's showing for me too.
Yeah, that's all I've got too.
Oh,
Sorry, it's been hard to tell
that's all
because
I
we're
got.
following the notes so
all
closely.
right, people.
I'm sorry.
Now?
That's much better.
Yes.
Oh, from the beginning. Okay.
Okay.
From the beginning. There we go. Now do you see it?
Yes.
Yeah. Yes.
All right. Okay, so I'll just slowly put it up there. So the first one was just open the airway. We're looking for obstructions. Okay, so we talked about those. I'll let you write those down. Should have said something because I'm nothing to look at. I usually like to take my picture off there. Okay, then the second one should be the breathing rate and pattern. And then what other things might you see? And that's when we talked about nasal flaring, accessory muscles, gasping, increased heart rate, and anxiety. Okay, everybody got those? Then we went to color, and this was pretty much just on your paper. So we talked about central cyanosis and peripheral cyanosis. And then level of consciousness, and then other signs and symptoms. There's restlessness, headache, increased blood pressure, irritability. We talked about slurred speech, and then all of those can lead to coma. And then the last one is blood gases. And you can just fill in those parameters. And that's just a review, because I think you should have had diagnostic of ABG results either in the summer or when you had your respiratory unit. You may have done a tic-tac-toe type method. You will be responsible for interpreting ABGs, so more than likely you'll have one or two on your first exam where you do have to interpret those results. So if you struggle with that, I would work on that just a little bit, or pull those old notes out and make sure you're aware of how you do that.
Are you going to want us to know partially compensated and fully compensated then?
Yeah, I think it's a good idea to know that.
Okay.
Because then you know how responsive their body is to what's going on.
Okay.
Because patients that can't compensate at all obviously aren't very healthy. Okay. All right, we should be back up to par now. So how do you decrease stress when you have somebody that has a lot of oxygen demands? Well, we want a quiet, non-stressful environment. And these are common sense things. So if you don't want to write these down, you don't have to. Keep their call light in reach. Reassure that help is available. And remember, the biggest thing is that they fear suffocation and death. Now, I've never had asthma myself or had respiratory issues, but I've choked on my own spit, those kind of crazy things, and you think you're going to die because you can't catch your breath. So I can only imagine when they truly have something medical going on, how anxiety-ridden this can be for them and stressful. Okay, the next one then is, what do we do to minimize physical activity? Well, you can delay personal care or reduce it to a minimum. So our patients that are truly respiratory distressed, we really don't want to do a lot with them. We offered to give a bath, or I shouldn't say me, but the students did, to a patient who was going to be extubated. And the nurse had said, no, let's delay this because we're working on extubating them. And they really didn't want them to use any extra energy. They wanted to be all focused on their extubation and minimizing respiratory effort. Efficient scheduling of your care and treatments. Of course, frequent rest periods. And we want to discourage them from talking or verbalization, just yes or no. We don't want them to have to go into a long explanation for us. So just common sense type things that you can do with your patient to minimize their activity. How do we keep their airways clear? Well, we can do effective coughing and suctioning. We can liquefy their secretion, so we can provide humidity on their oxygenation. We can make sure that they drink plenty of fluids unless it's contraindicated. We can use bronchodilators. We can call respiratory therapy to have them come do a treatment with the patient to break up some of the mucus if the O2 sat is decreased. We can reduce pulmonary congestion. Maybe the issue is that they have too much fluid on board. Maybe they're a congestive heart failure patient, and so the fluid is backing up and we need some type of diuretic to help reduce that. Remember, we would be looking here for some type of loop diuretic, a Bumex or a Lasix, because we want something to happen immediately or within a half hour to an hour window. Our oral diuretics take a little longer to work, and they are not as effective. And then maybe, with heart failure or some type of heart disease, we need something to improve the pumping action of the heart. So you'll see patients get put on digitalis in order to improve that system a little bit, so we can circulate blood a little better, we can get it processed through the kidneys, and we can excrete it. I don't have the next ones on a slide, but the next one is position. You've all seen patients that have difficulty breathing sometimes assume that orthoptic position, arms up on the bedside table or something like that, or they want to sit in their recliner, they refuse to get in bed for you. And then E, promoting good cardiac output. Remember, we want to keep a systolic blood pressure usually at 90 or above. Most of our hospitals, a lot of times will use a map, especially in your critical care areas. And usually we want to see a map of 65 or above in order to give your blood pressure medications and those kind of things. So keep some of that in mind. And then letter F is monitoring their hemoglobin status. Remember, we want a good hemoglobin. The oxygen does right on that. And I know they let patients get very low anymore, almost into the 7s, as long as they're not symptomatic. But a 10 or above is really where we would like to see our patients for good oxygenation. Okay, our next grouping are pharmacological agents that we will see the physicians and respiratory therapists and sometimes us use. So the xanthine derivatives, those are primarily used when we have COPD exacerbations. And our primary drug or prototype is theophylline, and we're looking at Theodure or aminophylline. So probably you've given Theodure, I would say maybe slow bid. Aminophylline is the injectable form. We don't see it used as much as what we used to years ago, but it is available still if physicians need it. Routes, oral, rectal, injectable, topical, really any place where there would be a mucous membrane, you can give a medication. Therapeutic levels, these are something that we can monitor. We want a therapeutic level somewhere between 10 to 20, and they can become toxic if it's greater than 20. They have a lot of GI symptoms, tachycardias, restlessness and stuff when the levels get too high for them. Severe reactions up on B, anything over 30 can actually cause cardiac arrest for them. You can imagine if we're giving something that stimulates the heart and they're at a very extreme or critical level, that the heart is definitely going to be affected for them. And if they don't have a very good heart to begin with, it can detrimentally affect them. Number 5, never give it IV push. You must dilute it and administer it very slowly. You know, that'd be like giving you a Red Bull right through your IV. We don't want to give anything that quick because they're definitely going to have some reactions to it. Letter B, it's closely related to caffeine. Caffeine can intensify the effects of it, so when they are given these medications, they are taught to avoid caffeine as much as possible. And then check compatibility, and what I mean by that is if you would have an IV infusion of aminophylline going and you need to give an antibiotic, you would definitely need to check that compatibility piece. Aminophylline IV is like giving heparin IV or cardizem IV. When you stop it, the blood levels go down. So we would not want to stop if they really needed an aminophylline drip for a vancomycin that was going to take 2 hours to infuse, because while you have it stopped, those blood levels are slowly decreasing. So you might need to start a second IV or something like that if you have this particular medication going. And that's number 6. That's what it's talking about, is what is the implications for a narrow therapeutic window when you're administering these meds. And it would be that you might have to start a second IV so that you are not stopping the medication. The little picture that I have here, she is toxic, and so she's amyloid toxicity, aminophylline toxicity. You can see that she's running, so we said it kind of speeds everything up. You can see that her heart is coming out of her chest. You can see that she's going to hurl, so she's got her hand over her mouth to kind of keep from throwing up. And you can see how wide her eyes are and how pinpoint they are. So those would be very classic symptoms of aminophylline toxicity for our patients. And she's a good one to be able to remember if you have a test question on it. If you can refer back to her little caricature, it'll help you get your answer correct. Our second one are beta adrenergic medications. Again, they're used in our asthmatic patients. The prototype for this one is albuterol. It does produce bronchodilation. It stimulates the beta-2 receptors. It allows the smooth muscles in the bronchi and the pulmonary vessels to kind of relax. It restores airway and it restores airflow fairly quickly for these patients. Some trade names, Alupent, Proventil, Xopenex, Xopenex. I know you've heard that one. Ceravent Discus. There's all kinds of medications these days that go into that group. The major side effect on number 4, again, is that it does increase the heart rate, and if you already have heart issues, it can cause angina and tachydysrhythmias in patients. So you do have to watch that. Our next group of medications are catecholamines or epinephrine. They are used in anaphylactic reactions or asthmatic patients, and we also can use it as a stimulant in cardiac arrest. So we will give epi when we do our ALS protocols, but we're giving it for a different reason than for breathing. So epinephrine is our prototype, or adrenaline. The dosages do come in different concentrations. So number 2, I'm not testing you on that by any means, asking you a question, but I do want you to know when the physician asks you to go get the medication because they're going to suture somebody and they want to vasoconstrict the tissue so they stop bleeding, I do want to make sure that you have grabbed the right concentration. Okay, we don't want you to mess up on that. They are very potent. They vasoconstrict. So when you give it sub-Q or IM, we do counteract that by massaging the area. So if you do an EpiPen or anything like that for a patient, you do want to massage the top of the thigh or wherever you've given it, so you can speed up the absorption for that. And then number 4 are adverse reactions, hypertensive crisis, because remember they can vasoconstrict. Angina, again, vasoconstriction is not just at the periphery. It can be coronary vessels also, and it can put us into dysrhythmias. And again, it's just due to the vasoconstrictive piece. All right, next medication. Opioid antagonists. I know you've all heard of Narcan is the prototype. It's used to counteract respiratory depression and the effects of overdosage of opioid narcotics only. It is not effective for hypnotics or anesthetics. If you overdose on sleeping pills, you cannot. It's not a reversal agent for any of that. Just opioid narcotics. You can give them sub-Q or IM. We also know that you can give them nasally also. In the hospital, we tend to do number 4, an IV dose. It works much quicker than sub-Q or IM or even nasally. It's effective within 1 to 2 minutes, and it lasts for less than about 45 minutes.
So it's not uncommon that you might need to give a second dose. So your physician may just order one dose, then you have to monitor the respiratory status, what are their respiration level, are they coming around, and if they don't, you may need to give a second dose for the patient. You need to monitor the patient. Reoccurrence of respiratory depression is not uncommon for these folks. It can cause withdrawal symptoms if you truly have a opioid addicted patient, so you'll need to watch for that. It does block the effect of your opioid medication, so if you've given this to a post-op patient who's gotten too much narcotic, you will not be able to turn around until probably about another hour or so and give them pain medication at a lower dose that will be effective for them. So do be aware they're probably going to be in some discomfort for a while. Better that they're in discomfort than we're sending them to the morgue because they had respiratory failure. So they won't be happy about it, but you can have peace of mind that you were able to catch the respiratory depression and try to reverse that. Number 6, use cautiously in patients with cardiovascular disease. It can cause changes in their blood pressure and heart rhythms. Sometimes too rapid reversal can cause nausea and vomiting. I've not seen too much with that. I've given it to general med-surg patients, surgical patients, where PACU has given them medication and then they've come up to the floor, and my orders were pertinent to be able to give more narcotics, and the patient just did not metabolize them as well as what we thought they would, maybe an older client or something, and we had to give them Narcan to reverse it. So it does happen. Nobody really, for the most part, has made an error. We just miscalculated how well that he could tolerate the medication. One of our other medications is Revex. This one is given IV also. It does inhibit the ability for narcotics to work for up to 8 hours. So would not be appropriate for a post-op patient, would be appropriate for somebody who's abusing narcotics. They're really not taking them for the pain medicated effect. They're taking it for the high that they're getting from the opioid. So you could use it for this. Again, you have to watch their blood pressure and their heart. And then Revia or Trexin, these are POs. These are things that they can give to patients that are opioid addicts to keep them in an opioid-free state. If they do happen to take opioids while they're taking these two medications, they do have some side effects of nausea, tachycardia. Okay, so these can be things that they can give to those patients long term. But 99.9% of the time, probably Narcan is the drug that you will see and utilize. Okay, our last medication then are going to be glucocorticoids. And glucocorticoids are an anti-inflammatory medication. They are used to decrease bronchial edema. So if you have somebody comes in with a COPD exacerbation, sometimes our pneumonia patients will get steroids just to kind of help decrease the inflammation within the lungs themselves. There's a variety of drugs that can be used, prednisone, Solucortef, Salumedrol, Decadrons. There's Asthmaport inhalers, Arabid, Flonase, etc. Those are all anti-inflammatories or steroids that they can use. They can be given orally, topically, IV, or per inhalation. Probably as our fall progresses here, you will see steroids given via the IV, and we tend to use Salumedrol or Solucortef. They come in a little bottle with a rubber stopper that you depress, mix up, draw up, and then you give it over a minute or so to the patient. Remember our protocol on steroids. They do increase blood sugars, so you may see blood glucose levels go up. Do remember that they cause insomnia. So if you're giving Q12 hours, Q8 hours, if you're giving a dose at midnight, the patient may complain to you as the day shift nurse that they didn't sleep. and they didn't sleep because they got a steroid around midnight. So we try to time those more like maybe a 6 a.m. and a 6 p.m. Normally your body shuts down the production of steroids by about 3:30, 4 o'clock in the afternoon so that you can sleep during the night. And that kind of throws that whole dealio off for patients when we're artificially giving steroids to them. Okay, any questions about that right now? Okay, I'll assume no news is good news. We're going to start with some pieces and parts to the tracheostomy and endotracheal tubes. So I added, I don't have them in my notes because I didn't print off a new one, but I added a couple pictures to try to help, and then I have some pictures through the slides. Since you're not in person and I can't really hold stuff up very well on a computer camera. But the first one that we're looking at are tracheostomy tubes. They come in a variety of sizes and styles. There's plastic ones, there's metal ones, and then they can come single lumen, double lumen. So the first one we're going to talk about is the double lumen. And in the picture on your notes, you should have three pieces, I believe. You should have an inner cannula, an outer cannula, and an obturator. And let me see. So you should have something that kind of looks like that. Yours is plastic, so it looks a little different on your picture. But this is your outer cannula. That's what fits directly into the stomal hole. Then it's a double cannula because this tube fits into this hole and it sits in there. And then the obturator, I'll go back to it so you can write some notes here. The obturator, this little, looks like a cotton swab, goes in here, and then at the outer tube, it makes a little rounded piece. So in lab tomorrow, I'll get them out, and I want you to feel how sharp the edge of that endotracheal tube is until we put the obturator in. When we put the obturator in, it makes a nice, round, smooth surface. There would be no trauma to the mucosa or to the tracheal tissue. Without that obturator in, this is very rough and sharp, and it could cause trauma to us. So those are your three pieces. So let me go back. The inner cannula fits snugly into the outer cannula and locks into place. The outer cannula is what fits into the stoma and keeps the airway open. It always has a face plate, and that's how we can secure it. We can put Velcro ties through, we can put twill ties through, however we need to. The physician can even put sutures through on a brand new trach. They'll suture and put the suture material through in the skin and then wrap it around that face plate. And then the obturator is just a stylet with a blunt end, and it's removed after tube placement, but we use it for insertion. So there's three pieces. And it's a double lumen because we have an inner and an outer cannula. All right, single lumen. Single lumen, there is no inner cannula. You have to do a lot of intensive suctioning and cleaning because there's no inner. So back here on this one, this is what we're going to take out and scrub and clean for our trach care. So on a single lumen, you only have the outer tube. There's nothing to take out and clean. So you have to make sure you suction real well, that they don't have excessive secretions, because if they do, and that hole plugs up, that's their only airway. Okay, so that's what we mean by you have to have a lot of intensive cleaning and preventing of clogging, because there's no inner cannula to take out and scrub or throw away and put a fresh one in. There just is nothing like that. Single lumens, they're usually patients that have had trachs for a while, or they're going to have them for quite a while. Patients sometimes with a little longer neck, you can get a little longer tube when it's a single lumen. they're kind of specialty patients. Most of them have double lumens because they're easier to clean and care for. But it's not to say that you won't run into a patient that has one of those. Cuff tube. The cuff just seals the airway and prevents aspiration. It does have a pigtail and a pilot balloon, and that tells if the cuff is inflated or not. And I think your picture shows that. So this is a cuff tube, and I'll go back to the writing in just a minute. So here's the obturator again, insertion only, right? Makes a blunt tip. Inner cannula is the piece that goes in here. Your outer tube is where your cuff is located, and I believe your picture in your notes shows you a cuff. Here's the little balloon or pilot balloon or pigtail. We would hook a syringe up to this, and we would put air in. The air flows through, and it inflates the cuff. The cuff being inflated in the tracheal tube keeps you from aspirating any secretions that would come down. It sits here on top of this cuff. It prevents, when they're on mechanical ventilation, that when the ventilator gives a breath down through the tube, that the air just doesn't go right up back around it. So you have to have a cuff in certain circumstances. You have to have a cuff when you need to seal the airway and you need the air to go down versus come back up. And you need a cuff when you have a patient who's at risk for aspiration. So if they can't handle the secretions, then they need to have a cuff tube. And that pigtail or pilot balloon tells if your cuff is inflated or not. And I'll pull all the pieces and parts out in lab. If you've never had the experience of touching or handling it, once you see it in person, you get a better grasp of what I'm talking about. Okay, so there's the cuff. A cuffless tube is for a non-acute patient, and a non-acute meaning they don't need to be on a ventilator. If you're on a ventilator, you have to have a cuff. The cuff keeps the air from coming up around the trach and coming out your nose and mouth. It forces it downward. So if you are on a ventilator and you're in an acute state, you have to have a cuff tube. If you are at risk of aspiration, you have to have a cuff tube. Okay, so non-cuffed are for non-acute patients that have a decreased risk of aspiration, because you can't prevent aspiration 100%. I can't keep you from choking on your soda or you inhaling Rice Krispie, if you are trying to breathe and swallow at the same time. So, it decreases the risk. But if you are known risk because a speech has told you that they aspirate on almost everything that they swallow, they have to have a cuff. And remember, they cannot be used for patients that are on long-term mechanical ventilation. So if they don't need a mechanical ventilator, they're probably going to be a cuffless tube that they utilize. Okay, we'll do a couple more of these and then I will let you take a break. You can also speak when you have a cuffless tube. You know why? Because the air is diverted now back up over your vocal cords and you can create speech. So as long as that cuff is deflated and air can come up over your vocal cords, you are able to speak with that in place. Fenestrated trach tube. There's pre-cut openings in the outer cannula. It is used for weaning. It allows for airflow to move in and out. It allows the patient to speak. And I'll show you a picture here. I think I have one. So on this particular patient, we have a cap here. See, they've capped off the trach. So now the patient is able to breathe in and out of their mouth. See the fenestration here? The cuff is deflated. Air movement is in and out, in and out. And this is just here, just in case we need to open it back up and utilize it. Okay? So in this particular patient, the fenestration, we're allowing them to breathe in and out on their own. They can handle their secretions. And all we've done is just opened the airway up and allowed for better airflow with a fenestrated tube. Again, we use it for weaning because we want them to start breathing on their own. We want to deflate that cuff. We want to put a little cap on the end and see how well they do. Now, if they need some type of supplemental oxygen while they're on this, we could do a mask or a nasal cannula. Okay, we wouldn't have to provide oxygen via their trach because we're allowing them to breathe in and out of their nose and mouth. Okay, so you can highlight that. They're great for weaning. And I'll put the slides out when it's over so you can refer back to them. Bivona foam cuff. I'll have a couple in the lab tomorrow that you can look at. These actually conform to the neck. There is no pilot balloon. There's a red port to it, and I'll show it to you tomorrow. But it's only closed with insertion, and then once the insertion is done, you leave it open, and it can compress. It's very soft. It's got literally a piece of foam on the inside of it. And it's used for folks that have tracheal malacia. Now, I'm going to have you step back in time. Do you remember when you did A and P? The tracheal rings are only on the front side of the trach, but there's none on the back. So the people that have tracheostomies with balloons inflated for long periods of time get a dilatation or a malacia. They lose their structure to the trachea. Well, when you do that, in the standard trachs, you can only keep them inflated so much. And then you're losing air out around it. This Bivona foam cuff there, it's a huge balloon, and it compresses and gets smaller and bigger based on what their need is as they're moving their neck. So I'll show it to you tomorrow in class, and it'll make a little more sense to you. But they are used for problems with the trachea, and the remedy for it is a Bivona foam cuff. And there's no need to check cuff pressures because the pressures change as you move your neck, and it's very soft and pliable. We're trying to get through number 9 here, and then I will stop and give you a 10-minute break. Metal tube, you do have a picture of that in your notes. They're cuffless. They're always a double lumen. They're for people who have a permanent trach, no mechanical ventilation, because if you look at your picture, what's missing? The cuff, right? And so in order to be on a mechanical ventilator with a metal tube, you would have to have a cuff. And they just don't put cuffs on the metal tubes. They last forever as long as you don't have an allergy to the metal that they're utilizing. What's to go wrong with it? You can pretty much beat them up, and you can still use them over and over again. So they're a very good cost-saving piece to patients. You can see they have a face plate on them. You can put your twill ties or your Velcro strap through it very easily. There is an adapter. If you look at that versus the picture right above it, do you see on your metal one how flat it is? That would sit very flush to your neck. Where would you hook your ambu bag to? Now, if you look at the picture above, you can see that there is a little nub that probably sticks up probably a half an inch. That's where your ambu bag would attach for those. So if you have somebody that comes into the emergency room, there is a special adapter for metal trachs, or you can take the metal trach out and put in a plastic one. So just FYI, in case you're working someplace where you're dealing with a metal tube, if you're a patient with respiratory arrest and you want to hook an ambu bag up, there is nothing to hook up to on a metal tube. You're almost better off to take it out either bag them via their stoma or cover their stoma up and bag them via their nose and mouth if they still have an open airway. And then the last one is, or next to last one is the speaking tube. This brand is a Passy Muir. I actually have a little snippet in your modules that you can watch on the speaking valves. It fits over the trach, it reduces airflow, or redirects the airflow over the vocal cords. You can use them for long-term ventilation so that those patients can speak. And then the last one is a decannulation plug, and it just maintains the patency of the stoma. So in case the patient is at high risk for aspiration or pneumonias or those kind of things, we just keep the stomal hole open, and we could take out the decannulation plug and we could put the trach back in if we needed to. All right, so everybody take 10 minutes. I have 11 o'clock on mine, so come back at 11:10, 11:11, okay? Take a quick break.